Hi, everyone. Today, in the next 10 minutes or so, I'm going to review some basic concepts of HCC epidemiology and showcase some of the work that we've done with the CLDF HCC subcommittee and highlight the recent HCC algorithm that we've developed. So as I mentioned, we're going to review some updates in HCC epidemiology, focus on highlighting disparities, and talk about the CLDF HCC Care Cascade Decision Support Tool that we've developed and is freely available to everyone to help improve management of patients with chronic liver disease and HCC. Some basic epidemiology that many of you are aware of. Globally, liver disease accounts for over 2 million deaths. Cirrhosis and viral hepatitis, as well as liver cancer, contribute to a majority of these liver-related mortality. And cirrhosis and liver cancer account for almost 4% of all deaths worldwide. And liver cancer in particular is the third leading cause of cancer-related deaths. In the US, liver disease and cirrhosis also account for significant morbidity and mortality. HCC is the fifth leading cause of cancer deaths. And despite availability of treatments for HCC, overall 5-year survival is less than 30%, primarily due to delays in timely diagnosis and treatment. Understanding gaps and disparities can help guide targeted interventions. In many ways, poor clinical outcomes are preventable. If we can identify cancer early, we can help patients get access to potentially curative therapies. And this is through early detection, timely access to effective therapies, and especially intervention through education and prevention at both the patient and provider level. As we know, there's also complex socioeconomic disadvantages, and vulnerable populations in particular experience the majority of healthcare disparities. And this compounds existing healthcare inequities that these populations face. And really, the goal in improving HCC care is to try to identify comprehensive ways, particularly to address low-hanging fruit that can have a significant impact on improving liver disease outcomes. This is sort of the care cascade model for chronic liver disease that I like to think about often in my patients. And as you can see here, ultimately, the downstream goal is to reduce HCC, reduce liver mortality, reduce risk of cirrhosis. But the upstream cascade shows several opportunities where patients can experience delays in gaps in timely linkage to care and retention to care. And it really emphasizes the complex care cascade involved in chronic liver disease, as well as HCC screening and early diagnosis. While it's very complex, I think there are a lot of different factors that play into timely and appropriate HCC surveillance. Some of these include patient factors, provider factors, and system factors. And in many ways and in many situations, there are interactions across all of these domains that ultimately impact timely and appropriate HCC surveillance. What are recent updates in HCC epi? We know that there's a declining incidence of Hep C-related HCC due to Hep C cure regimens. We're seeing increasing burden of NASH-related HCC as a large population with fatty liver or steatotic liver disease are aging and developing liver-related complications. And as I mentioned a little bit earlier, despite these improvements in HCC treatment options, overall 5-year survival in the US remains less than 30%. These are recent data from the National Cancer Institute SEER data. And as you can see here, while overall incidence and mortality of HCC has somewhat plateaued, there still remains significant disparities with respect to race, ethnicity, as well as gender-specific disparities. And it really highlights not only etiology-specific differences, but really the delays and gaps in care that may influence some delays in timely diagnosis and access to treatment. HCC surveillance is perhaps one of the most important steps in the early cascade. However, recent data, especially the one highlighted here, show low rates of HCC surveillance. This was data published 2021 of 29 studies in the meta-analyses and show that HCC surveillance among cirrhosis patients was only 24%. As you can see here on the bottom, in addition to overall low rates, there remain significant race ethnicities differences in stage of disease at diagnosis, as well as timely treatment, with ethnic minorities in particular more likely to have advanced stage of tumor at diagnosis and less likely to receive a treatment or potentially curative treatment for HCC. As I mentioned, HCC surveillance is perhaps one of the most important steps in the HCC cascade because effective surveillance leads to early tumor stage of diagnosis. Tumor stage directly correlates with treatment options, with more options for curative intent and therefore better long-term survival. Understanding and addressing these disparities is important to reduce downstream disparities in outcomes. And as we mentioned earlier, there's really a complex play between patient, provider, and system level factors. To try and address some of these disparities through education and providing guidance in the form of a digital interactive decision support tool, we at the CLDF HCC subcommittee developed this free online web support tool to help improve patient care in the HCC care cascade. In the next couple of slides, I will show a few examples of the cascade. And then at the very end, we'll actually log on to the algorithm and go through an example of how to utilize this. This is sort of a screenshot of the algorithm that is behind the scenes. This one in particular shows you the decision support steps involved in identifying who needs screening, how to screen, and how to interpret the different results from imaging-based modalities. Once HCC is confirmed, our algorithm also incorporates the BCLC staging algorithm to help improve providers and patients accurately stage their HCC and therefore help improve linkage to appropriate HCC targeted therapy. So HCC remains a leading cause of cancer-related mortality, both in the US and globally. We know that there are disparities in timely diagnosis and treatments. Gaps and disparities in screening and surveillance persist, and really novel interventions are needed to improve outcomes, especially the care cascade. And we've developed one here, and if you want to acknowledge our committee and the CLDF support team that helped develop this algorithm. And if you want to scan this QR code, it will link you directly to the web page that has the algorithm, and you can follow along as we go through this. So now I'm going to, let's see, bring up the algorithm here. Bear with me. Perfect. So hopefully you can see the screen here. So if you scan the QR code, it'll bring you to this web page. And on the introduction, it gives you some information about the care cascade. And you can go down to this button here to access the algorithm. And there's some information here. You can put in your information. So I'm just going to put in some information here. And then you click this to continue. So this first menu is very helpful. For those that want specific guidance about a specific area, you can click on the topic that interests you, whether you want screening guidance, you want some help interpreting LIRATs and follow-up recommendations, you want info about staging and treatment. We also have a useful HCC calculator and resource center. We have a nice list. This is recently added where we can search for liver transplant centers and associated services in your area to help you link your patients to appropriate care. and then also linking to industry-sponsored patient assistance programs or clinical trials. So I would just start at the top to give an example of how we could use this, for example, a patient with chronic liver disease. So first, does this patient have cirrhosis? So I'm going to use a sample patient with cirrhosis. So it tells us here, based on the guidelines, that recommendation for ultrasound screening with or without AFP every 6 months. We're going to continue. We found, does your ultrasound show a liver lesion greater than 1 centimeter or AFP greater than 20? I'm going to say yes. So then the guideline or the Cascade recommends multi-phase contrast enhanced imaging with CT or MRI. Based on that, here, the figure on top shows the categorization of the LIRADS criteria. Most, if not all, radiologists will report the lesion as a LIRADS score. And based on that, we have recommendations here on the bottom about what next steps to take. We also have a really nice table here that gives the average probability of HCC based on LIRADS and the reference if you are interested in looking at the evidence supporting this. So based on this hypothetical patient, this person has a LIRADS lesion 5. So that's, as you can see up here, very high probability of HCC. So I'm going to click LIRADS 5 and see what the Cascade recommends. It tells us that HCC based on LIRADS 5 is confirmed. And now the next step is to stage the tumor. And we took this, referenced this from the BCLC criteria as referenced here. And you can use this to guide you to accurately stage your patient. And that will then, you can see on the next steps of the Cascade, guide you to appropriate treatment. So for my hypothetical patient, this patient has early stage A, had a single lesion with preserved liver function and good performance status. So I'm going to click early stage A. And you can see here very nice summarized treatment guidance about what are the treatment recommendations for BCLC stage A. You can see here the potential curative therapies, other things to consider that may be unique to your region or your country, are different criteria for HCC liver transplant eligibility, as well as downstaging criteria. So this is very important guidance about potential treatment. And then advanced HCC tumor characteristics. So these characteristics of your patient, if you put in, you'll see that it'll generate a summary for you to take with you for your patient or to send to your referring center. So for my patient, I'm going to say is Child-Pugh A, performance status good, as I mentioned. This one had a single lesion and it was 3 centimeters, let's say. The patient had a single tumor and the total centimeter was 3 centimeters. And this patient did not have main portal vein invasion or extrahepatic spread. So then after putting in these details, I'm going to advance to session summary. And you can see here that it puts together in a very nice table the summary of your patient and the patient's tumor characteristics in a nice table format. And if you want to get an email of this, you can advance here, put in your information, and the Cascade will then email you these details so that you can put in the patient's chart or use as a reference when referring. So that's pretty much the algorithm. I'm just going to restart it here to show you back to the beginning and in chronic liver disease, and really invite all of you to play around with this. We went through screening, LIRADS, staging, but there's also some of these other categories for you to explore. It's a very useful tool, and I think will really improve patient care and linkage to care, especially these newer additions that we've added to help link to specialty centers for HCC treatments in your region. And thank you for your attention, and hopefully you will find this algorithm helpful for your patient care. Thank you.